Right, well, good evening and welcome to the webinar, Getting Started in Telehealth, Patient Workflow, Care Protocols, and Clinical Quality. My name is Carlene Ketela, and I serve as the CEO of the Michigan Academy of Family Physicians. And on behalf of the Academy, as well as our Family Medicine Foundation of Michigan partner, we're delighted to have so many of our members with us this evening. Our faculty for tonight's session is MAFP Board of Directors Vice President, Dr. Srikar Reddy. And Dr. Reddy will share his insight on how telemedicine has become an essential skill in family physicians' response to COVID-19. Our next slide includes some helpful prompts as we look at technical support. If you do have any issues during this evening's webinar, please feel free to contact our meeting planner, Dana Bunting, at dbunting@mafp.com, or if you're comfortable, just to type in your question within the chat box located at the bottom of your screen. Next slide. Just here are some webinar shortcuts for those that are new to the Zoom format. We do have to the left, it indicates whether or not your audio is connected. Also, you can also see the arrow that directs you to the chat box. And then lastly, if you want to look and type out a question, please share it to everyone. And we'll be, at the end of the webinar, we'll be reviewing all of the questions that have come in. So please feel free to type out your questions as we move throughout tonight's webinar.
How do I get it to the speakers?
All right, next slide. And as always, in these times and always, we do as an academy want our members to stay connected. For those of you, we do provide a MAFP text message service that we provide timely updates to. That's located on the screen here. We also have a continuing, evolving COVID-19 webpage, and it's become such a great resource related to state and federal policy that's coming out, as well as updates. And also we do have a COVID-19 online member discussion portal that members are using just to share questions related to billing or other experiences that they're coming into contact with. And so that's been a useful tool as well. And then I also want to mention next week's webinar. We will be providing an update related to COVID-19 and what our partners at the American Board of Family Medicine are doing to in relation to their certification activities, as well as the residency training requirements. And then at this time, I would like to turn the microphone over to our speaker, Dr. Reddy. Welcome, Dr. Reddy.
Thank you, Carlene. So thank you all for joining us this evening. This is an important topic that, moving forward, not just during the COVID pandemic, but I think for the future of family medicine, it's going to be very important to understand the role digital health and telehealth will play in our practices. I'm going to keep this relatively informal. So we have some slides we're going to go through. We have solo physicians, private practice physicians, employed physicians, academic docs. So, we want to get to the basic crux of what telemedicine is, what virtual health is. There has been some questions that have already been put out there through the MAFP portal, which I'll address after the short presentation. And then for the last, hopefully 25 minutes or more, we will address question and answers, and that we can, because I know there's a lot of concern, there's a lot of questions in regards to telehealth. So let's get started. So when they mention the term telehealth, it's a broad term. So telehealth encompasses, different forms of virtual care, telemedicine, whatnot. So one form would be live video. So live two-way connection between a patient and provider. So essentially a face-to-face interaction, what we would do in our primary care office. Another would be what would constitute store and forward technology. So that's where a provider sends a recorded health history, such as scans, photos, and that goes to, it could be a specialist, it could be a provider, but it's actually where the physician or provider is reviewing the material that is sent to them through a HIPAA compliant platform. Another one is remote patient monitoring. So that's where we're monitoring vital signs and transmitting information to a provider. So this is where you have a team, clinical staff, nursing staff, where you can actually monitor the patients on a day-to-day basis and communicate with the physicians through digital technology. This is especially important right now with the COVID pandemic, as far as keeping the hospital beds clear for those patients who maybe not as high acuity or not as many comorbidity as others. So it's good that this technology has already been used, is really on the rise, because in times like this, you really want to free up hospital beds. Mobile health, that's the use of mobile communication devices in health practice and education. That's more patient education, information through smartphones, Androids, and just easy accessibility. Next slide, Dana. Some of the benefits of telehealth. So convenience. So you're delivering like behavioral health services from your home, office, or when traveling. We all know as family physicians the need for behavioral health, mental illness. I think, at the recent advocacy meeting in Lansing in February, or one of our, I forgot if she was a lobbyist or she was a representative for the Michigan Department of Health, but she had mentioned that, young patients, they're more comfortable seeing a physician on their iPhone than they are in person. We have to deal with a generation of not just millennials, but people who are consumers and who want access, and convenience is a big factor, and we have to take that into a large consideration, because a traditional way of the thought process to always say is, this is the way we do things. This is the right way we do things. Well, there's not always a right way of doing things. We have to, it's shared decisions, and we have to really follow on consumer patterns and what patients want. And this offers this convenience. It's simple. So, when you use simple, I guess, is a relative term, right? So when you're using your private computer with a camera and high-speed internet, if you actually look at now how much technology, things are getting advanced, this is relatively, from how we're using it, 90% of the time in the form of virtual visit, simply requires internet and a computer and a camera in order for it to be a virtual visit. So we try to simplify it as much as we can in order to make it accessible for both providers and patients. It's an opportunity for extra income. So just to give you a brief background, I was in a small group private practice in Brighton Family Physician in Brighton from 2010 to 2015. I opened my own solo private practice in South Lyon, Michigan in 2015. It was a developing area, it was very close to my home. And at that time, I discovered as a way to, have an adjunct to my practice, and while my practice was building, was, really to think outside the box and use technology. And, that's where I really learned telemedicine. That started in about 2016, where I, as opposed to spending my time where I had some experience with urgent care, was to use this new platform through like locums work. And it really opened my eyes. And since then, I've been really advocating for this, because for the first time, family physicians are at the crux. We are the forefront of medicine, no matter which way you look at it. And the pandemic has really brought that about, because what other physicians can treat patients from birth all the way through geriatric patients without having limitations on the patients they can see coming in through a platform that is not just a patient who is going to be coming in through your door. So those who are in medical school, those of you in academia, I encourage you to really reach out to those in medical school and say, we always used to think of it like you have to wait for patients to come to you. You have to find a place where there's patients. Well, now you're looking at patients all over your state, or if you're licensed in multiple states, all over where your office is open to all. And because you have do such a large scope and you're comfortable with all age groups, all of a sudden, there's so much room for growth. Secure and private. So HIPAA compliant platform is very important. However, we'll get into that a little bit later. Right now, because of the pandemic, the federal government under CMS has loosened those guidelines, but it is still important just to practice good medicine, to do the best you can as far as keeping HIPAA compliance, because eventually, sooner rather than later, those guidelines will be more, distinct. Open access to more patients, like we just discussed. We can treat patient members who live in rural areas or with mobility issues, kids, in schools in rural areas who right there from the school, instead of going home, can access a physician. How wonderful is that? That they can access a healthcare provider, physician, that without having to leave the school with simple use of technology. Reduce no-shows and cancellations. So, how it is when bad weather, limitations on the patient's location. Now, no matter where that patient is, and they know that you can communicate with that patient. So it definitely would reduce the no-shows, cancellations, and should supplement your general practice quite well. Next slide. This is a very busy, very busy slide, but just to show you. And Dr. Scott Ethorn, who he works with at Ascension on the national scale now. Now, Dr. Ethorn and I and Amy, Dr. McKinsey, who is on the Family Medicine Foundation, she works for Blue Cross Blue Shield. So we did a presentation in July up north and that was titled Virtual Care, the Future of Family Medicine. And it's really great. And I just want to throw in a little pitch for the Academy, is that, Dr. Ethorn is a sports medicine family physician who now works with Optimal Care. Dr. McKenzie, works for Blue Cross Blue Shield, who has now opened up telemedicine from Blue Cross Blue Shield with no copays till the end of June. Being able to collaborate through an academy like we have with people in different lines of different ways of practicing family medicine, that collaboration is great, and it lasts, and it's coming to fruition now, as we're going to be seeing a different era after this corona pandemic on how medicine is practiced. And so I'm glad, please utilize your academy, as Carlene had mentioned, ways to communicate, because it's really great to be able to collaborate with other physicians and other family physicians specifically, to not just advocate, but kind of open up and educate everyone around us. Going back to this slide, this landscape is basically showing you different companies or investors, the big ones, in these different forms of telehealth. Like with telemedicine, American Well is a platform we use as from private practice. I then merged with Ascension in 2017, as most of my patients were using the Providence Park system. It's within a few miles from here. And when I came on board with a large health system, it was great, because they were really looking at staying ahead of the curve with technology and moving more toward ambulatory virtual care. And that's kind of where it gave me a lot of, interest. And so we've been helping with Ascension as far as helping them on board with the telemedicine. And so right now we're using American Well, which is a big one. We've used MD Live in the past. That's another, one of the big vendors, we call them, and Teladoc, as well as Doctor on Demand. Those are what I would call like the big four as far as consumer-based consumer-based virtual care, which is what you think of when you think of a patient picking up their phone and accessing a physician with a couple clicks of a button. Remote patient monitoring, this is more, has to do with when a patient would leave a hospital setting or a respiratory care clinic, or a patient who's been discharged from the hospital. We wanted to keep a close eye on with almost like a home care team. And we need to use some digital health and some technology so that we can monitor this patient without having to keep them in a tertiary center. Medical alarm systems, these are some big companies involved with that, and just mHealth, some of the big companies, Google, Amazon, they're all really investing in digital health and virtual care at this point. Next slide, please. So these are just 2 slides. So, the COVID pandemic. So just a brief background, I was, through, Ascension, which is a national hospital system, and under Dr. E. Thorne, we were really promoting for virtual care and promoting it amongst our physicians, as I mentioned, for the last maybe 6 months to a year is really when we were getting these things going. And then, as we all know, about a month ago or so, everything changed from an ambulatory setting. Everything changed for everybody in solo practice, small group practice, employed practice, every practice. And all of a sudden, it's no longer about convincing physicians that they should learn the technology of telemedicine or virtual care, but how do we implement it? How do we quickly implement it in order to sustain our practices, provide good patient care, and still do it the right way that we learned, that we all know as far as good quality medicine. And that's the hard part, and everyone has different comfort levels. And so that's the part where, hopefully today we'll help you a little bit. Hopefully you get a little bit of, information that'll help you as far as what fits you and your practice best. This one picture here, this is Roy Schoenberg. He happens to be the CEO of American Well, which is a platform we are using right now. And some of him and some of the other, the big company, they've been so overwhelmed over the last, 6 weeks or a month that, they can't get enough physicians on board for wait times. And so they also, it's been the bigger problem has not been implementing or getting people to understand virtual care now, as it is getting enough physicians who can meet the demand, okay? Luckily, things are getting better here. We've seen, at least from a virtual care standpoint, over the last week or so, as far as new cases, and so patient access has gotten better. Second picture here is, you see Seema Verma, Dr. Fauci, Surgeon General, President. So as I'm sure some of you are on this call because about 3 weeks ago, or a little over, the CMS opened up, and they had been advocating for this for a while under this administration, as far as opening up some of the guidelines for what constitutes telemedicine and what would be compliant and what would be billable. And that simply, they worked it out quickly because of the need to adapt given the crisis. Next slide, please. This is just, just a basic picture. I borrowed this from, American Well, as far as just kind of what on your smartphone, how you would see, how you would, log in. You would see, on this platform, you would see a list of providers, brief history, and you could click on them, and then they should be available, and it would show you, you can see up there approximately like what a wait time would be to see that physician. Next slide, please. So how we select patients for virtual visits in your office as a family physician. So for us, as I'm going to try and steer this towards outpatient family physicians, would be, if you're getting started, would be patients with an established relationship with their clinician. Patients, you have a good understanding as a family physician of your patients, and those who would have a basic understanding of technology. And you don't want somebody who has a lot of comorbidities, right? That would be addressed in one visit. So that would be ideal. Now you can still address those, obviously, through a virtual visit, but that would be an ideal patient. You want to avoid, if possible, medically complex and unstable patients where, if you know for a fact that you need to do the certain physical exam components that are going to be necessary, if possible, you should arrange for an in-person visit versus a telemedicine visit. Patients who are due for physicals that require procedures, vaccinations for children. So I know now I've advised some pediatric practices, they are very on board with doing their exams even virtually, except for when you need immunizations, in which case the patient should come in. Same with procedures. You know, as of right now, we can't do pap smears via virtual care. Patients who have not been in the office for a visit in over a year, because, you know, you want, you know, if they haven't been in over a year, it is good always, you know, to put your hands on them, do a physical exam. That's the whole point of a physical exam. So it is good, if possible, to at least have them in your office annually. Next slide, please. So an ideal patient in my practice would be a stable patient. Let's say they had major depression, had an in-person visit once or twice a year. An in-person visit, I would say once a year. Here's us twice a year, and a virtual visit twice a year in between to address medical concerns. So the virtual visit, you know, a 6-month follow-up for medication, treat symptoms and whatnot, those would be something you could do. You do a this slide got cut off a little bit, I apologize. You could do a PHQ-9. Those are all things as far as behavioral health you could address without necessarily having to have an in-person physical exam. I'm a strong proponent of family physicians doing as much behavioral health and mental health treatment as they can. And what better way to see those patients regardless of where they are than through a virtual visit. Next slide, please. All right, next slide. So for those of you new to this virtual care and who are, you know, I already see some questions popping up like doxy.me, different types of platforms. So let's start from the basics. Is patients are very new to this. Most patients are very new to this, just a lot of physicians are new to this. So how do you get the patient comfortable? Let's think about that. So number one, I would wear appropriate professional clothing. Patients are used to seeing you dress professionally in a physical setting, and the same applies when you're providing care online. This is bridging the gap between what they're, you know, used to in an in-person exam. You still want to maintain that level of professional communication because they do look up to you, they do value your opinion. Always wear professional attire. Now that being said, you know, white coats are great. You know, we do recommend, you know, lab coats. It's kind of an emblem of being a physician, but if not, you know, like maybe a button-down shirt or, you know, nice scrub tops, sit in front of a simple background. So patients will be able to see you best if the environment behind you is simple, solid color. Many providers opt to purchase a room divider, which removes the distraction of your background. I edited some of these slides. That was taken from, you know, this was from what was recommended by the provider I use as far as American Well goes. You know, not necessarily my opinion as far as the room divider goes, but basically what I would state is sit in front of a simple, you want to keep a neutral background as best you can, or if you have an office in your home, that's always great background as well too. Just put yourself in the place of the patient think of them as this is their first time. Anytime someone is seeing a physician, there's always there's always a little bit amount of you know, anxiety and concern, and that you can quickly make that easier for them. Practice in a HIPAA compliant space. So you want to keep the door closed. You know, you try to avoid kids jumping around, playing around in the background to the best of your ability. You know, because you know that patient is giving you their time. Sometimes as a direct to consumer, they're spending money for this. They want your focus, and that's important to take into consideration. And you know, you want to make sure that you're in your home, in your office. Car is not an acceptable place to practice telemedicine. Next slide, please. You want to sit about 2 to 3 feet away from the camera. You know, always test whatever platform you're on, always test it out first. See where you are as far as distance and if you want to look into the camera as opposed to your screen when you're talking to the patient. Just like, you know, in med school when they walk you through it and you enter now, there was so much of that as far as the training of the patient interaction and how you present yourself in a room. Same thing. It takes a little bit of time to get used to, but you will get used to it as far as that interaction. Looking into the camera, keeping a good distance so that you're not right up in their face, you're not typing away, you're not opening a book so that all they see is your book. And you want to ensure proper lighting and, you know, controlled background noise as best as possible. Next slide. I keep a headphone or a headset on hand at all times because in case you get background noise, technical issues, it's always good, or there's some other noise going on in the area, in the place where you're working, it's always good to plug your headphones in and use those, and always check those just like you would your camera settings and sound settings on whatever platform you're using in your computer prior to the visit, and I encourage patients to do the same. Confirm you're available on the provider callback number. Very important because let's say, especially during these times with, especially during these times is that bandwidth, right? We all know that issue with the internet, the way things are, and technical issues. So best way to handle this situation is make sure you get the callback number because you can always convert this to a phone call, this visit in that situation. Confirm their date of birth, confirm their location. Next slide. And I say that about the location because you are licensed in the state of Michigan. If you're licensed in the state of Michigan, the patient needs to be in Michigan. If you're I'm licensed in Ohio, West Virginia, and Michigan, the patient needs to be in Ohio, West Virginia, or Michigan. I can be wherever I want in the United States, but the patient needs to be in the state that you're licensed in. Now, as of a few weeks ago, I mentioned this, Centers for Medicare and Medicaid opened up those to say statewide restrictions are down. I do not recommend that you practice in states where you are not licensed. I say that because states have different regulations than the federal government. Therefore, although the federal government cannot, will not enforce those, states may, and so if you are not licensed in that state, or unless you seek consult with that state's health department, please do not just go out there and say, okay, I'm going to start seeing patients across state lines. But that's why I mentioned as far as making sure that that verifying with the patient that they're in that state that you are practicing. Otherwise, you let them know that you cannot see them. This is a slide that goes as far as the federal, CMS, as far as the new CPT codes for virtual visits versus telephonic visits. And let's move away from this because it's a lot of information. I don't want to get in on this. I do have my practice manager, Lisa Welch. She's been doing virtual care telemedicine with me for the last 3-4 years and helping my practice run very well. And so she's an expert with the billing and whatnot, but even being an expert, these guidelines consistently change. What I would recommend is this. For virtual visits, you code those visits between this 99212 through 214s like you would in the office, and you have to put a location code because right now they are reimbursing similar rates for the moment, and we'll address this later. They are reimbursing very similar to inpatient visits during this pandemic because they understand the crisis. So you would basically put a 212, 213, 214 for established patients with the modifier. And as far as, you can do the same for 201, 202s, 203s. Now, that's for virtual visits, okay? It's different for, and I believe, and Lisa, correct me if I'm wrong, that it's a little bit different for the Medicare codes, right? I see you're unmuted. Okay, well, she's getting on. Let's go down. So the 99421, 422, 423s. Now that's what we were initially using. Here it's putting those down as e-visits. And again, within the time frame that we have, I don't want to get into this too much, but those are, we can use those for telephonic conversations. Let's keep this basic. Here's what I recommend. Everyone should be trying virtual visits, whether it be Doxy.me, Zoom, Hypnosis, whatever platform you have, try these virtual visits. The virtual visit doesn't work out, you switch that over to a telephonic visit. Telephonic visits are billed by time. So the 421 would be 5 to 10 minutes. 422 down there would be 10 to 15 minutes. 423 would be 15 to 20. And those are billed by time. So that way you are still getting reimbursed. the reimbursements are not as high for the telephonic visits. They don't require as much documentation. You're not documenting a physical exam. You just need to have that patient scheduled and document that your time and document your visit on your EMR platform or however you would in your office, and then you can bill for those patients as a telephonic visit if your virtual visit doesn't work out. All right, next slide. Okay, oh yes, let me just mention something to you. So the physicals, okay, annual exams. Right now, every insurance company is a little bit different. I would not encourage your annual exams to be done for virtual visits, but except for Medicare. So for established Medicare patients, G0438, G0439, you are free to do, and you can bill for those Medicare annual exams. The part that's important is for the exams, for the Medicare exams, you need to have objective data, unlike other virtual visits. Therefore, the patient needs to have a caregiver, some form of someone who has some competency, whether it be a caregiver or a spouse that can take their blood pressure and weight and have a weight available. You can kind of walk them through a respiratory. But those are important. If they can get a BP blood pressure reading and a weight, you can do you can conduct the annual exam. You'd have to walk them through quite a few things. If you have an MA in your office, I would recommend using your MA, because obviously you know that annual exams for Medicare can be a little more detail oriented than a regular a sick visit. And so, but to answer the question that comes up often is, right now, yes, subsequent Medicare annual exams, not welcome to Medicare, but the other ones can be billed as a virtual visit. Okay, so we are halfway through. We're at 7:33. So let me, before we address some of the questions that have been put on the portal, let me actually address some of the questions that were actually emailed to the MAFP earlier this week. How is medical liability? It's not bad as far as the cost-wise. Oftentimes it's very marginal if it's an addendum to your current malpractice. Oftentimes it's covered under it with no additional cost as far as your malpractice goes. If you're looking for part-time work with a direct-to-consumer based telemedicine company, they will cover your malpractice. It's oftentimes like, let's say you get per consult like a $30 fee, $35 fee. It's usually $1 or $2 they take out of your fee to cover your malpractice. How do you suggest documenting the mode of communication used for telemedicine visit? My practice is in Detroit, and the majority of my patients do not have computers or iPhones. I'm concerned the insurance companies do not have a clear understanding of the true socioeconomic differences of the urban communities. Will telephone consultations be accepted? Yes, they will be accepted. But you need to have your front desk, however you would schedule your patients in your office, you need to schedule that patient. And you can schedule that. You have to train your staff. Nothing is, you still have to do the work. You have to train your staff to put that in as a remote visit, or however you want to call it, telephone visit, in your schedule. And then with the conversation you have with the patient, you need to document that, and you have to document the time, and then you can submit it under those codes, 99421, 99422, 99423, and they will be accepted. And so when you mention the socioeconomic status factor, I know I have, my brother-in-law practices in rural Ohio, and he was getting somewhere around, he's getting like $40 to $45 per telephone consult, whereas, in our practice, which is not rural, we get maybe $20 to $28, bill out $28 for a 5 to 10 minute, and we get like $22, $23 for those visits is what our reimbursements are. And because sometimes, depending on the area, the insurance companies are trying to figure out the socioeconomic differences and try to accommodate for the lack of technology in various areas. To answer your question. Let me make sure I got everything on that question. So yes, so So I think we covered that. Any template for this telemedicine that includes protection from lawsuits? No, I don't know of any templates anywhere that can protect any of us physicians from lawsuits, because, the thing is, and we don't have that much, as much time today that we could cover as far as, practicing good medicine. And we can maybe do a separate topic webinar one day on a thorough physical exam. So let's go back to that as far as the physical exam goes. So things that you can use. See this pen light. You have the patient open their mouth. You can have them look in the back of their throat. If you can't visualize that, you can have their mom. You can have them look in the mirror and look for tonsillar exudate, tonsillar enlargement. You can have them, and you document this under your physical exam. You have them bring their head back. You have them feel underneath their lymph nodes. You can walk them through this. Everything comes with a little, you get used to this over time. It takes a little bit of, time to get comfortable walking them through these exams. Have them feeling for their lymph nodes, walk them through that. Frontal sinus pressure, maxillary sinus pressure. You just document the 1+, 2+ maxillary sinus pressure on self-palpation. Walk them through how to palpate on their, the suprapubic area if they're complaining of a urinary tract infection. Flank tenderness. You can have them, there are different ways that you will get comfortable as far as walking patients through that physical exam. And let me tell you something, patients really, really appreciate these virtual visits more so than they do even seeing you in person in their office for the most part, based on what consumer base and data is showing. They love the fact that you are available for them, walking them through some of these things on this virtual visit. Even if the visits are short, usually if a patient sees you in the office and your visit is short, sometimes you'll get negative feedback. Doesn't seem to be the case with virtual visits. That being said, on certain things you will not be able to, there are plenty of things that you cannot figure out on a virtual visit, in which case you think of it as a triage system. You will then tell them, okay, you need to come into my office tomorrow. You need to come into my office the day after, or you need to go to the urgent care or the emergency room based on your clinical judgment and the limitations of a physical exam, which I always mention to the patient at the initially when I'm taking their date of birth and checking what state they're in, I simply say to them, Mrs. Johnson, you do understand that this is a virtual care consult and there are limits of the physical exam that we can consult. Do I still have your permission to proceed with the consultation? And then they say yes. That's one way you can, to answer that last question, you can cover your liabilities as far as, I guess, you're concerned with lawsuits. Okay, good template algorithms for common telemedicine complaints. There are, I work for a large health system. We work with a national consortium. There's about 8 of us leads under Dr. Ethorn. We have some leads in Texas and Wisconsin, Tennessee, and myself from Michigan. We've come up with some clinical guidelines which we use for our providers. You can see guidelines available on the American Medical Association. I think has a decent platform. The best one, one of the better ones I've seen so far for the AMA. And don't quote me on the AAFP if they have those out yet. I haven't been able to review those, but the AMAs are pretty good as far as virtual care clinical guidelines. Eventually more will be coming out and you will have a set of clinical guidelines. Family physicians, you typically, from my experience, don't have much of an issue with this. Right now during the pandemic, we have gynecologists, we have endocrinologists, a lot of these physicians who haven't had as much experience in the ambulatory setting, seeing a wide variety of ailments as we have. And so they love to have these guidelines because they really want to come out and they want to help. So that's a little bit more important, and it is important to have those guidelines for them. Okay, I have been answering my phone and done a lot of triage rating for services. Have I missed hospice, home care, PT, COVID testing? Have I missed these opportunities? Yes, you have. You're not missing opportunities. I wouldn't think of it as a missed opportunity, as an opportunity for growth. And yes, you can through those telephonic conversations. And there's different billings for remote monitoring, which you should look into as far as documentation and being reimbursed for those services. Are they planning for a D-Day return with conditions to be met before return to business, hence May 1st and rules and regulations agree that they will reduce the chance of a significant spike of the curve face mask. Okay. So simply, I don't have the answer to that as far as, return to business. In correlation to telemedicine and virtual care, I think with all insurers and with all, large population health, I think they will see how the trend goes, how much money they're gaining, how much money they're losing from an insurance standpoint, and then decisions will be made as far as what they feel is maybe their sweet spot for reimbursement. So I don't know that it will consistently be the same. I don't think that may or may not be feasible. However, the general trend is going more towards virtual care. Maybe they will reimburse the same if they feel like they're spending less on procedures in hospital, and spending less or losing money in hospital. So we don't know. But for right now, reimbursements, should be good. Can we forecast a month or two from now? I couldn't tell you. Looking for basic information with the expectation that telemedicine will be expanding, and if not permanently, at least for the rest of the year. Yes, it will be expanding. Most likely, it will be expanding into the fall. Possibly, again, I can't forecast everything, probably maybe into next year. And will it telemedicine be expanding? Like I said, I can't document reimbursement, but yes, the way every large healthcare system that I've dealt with, I've spoken with, Kaiser Permanente in California, Providence, not the Providence Ascension, but up in the state of Washington. Healthcare will never be the same again. They will be moving more towards artificial intelligence, digital health. There'll be a lot of things that will be changed. Now, does that mean that you cannot practice full scope of family medicine? Absolutely not. Like I said, this is the best place for family medicine where we're going to be given the most value. There's still plenty of patients who want to go in and see their doctor in the office, and there's nothing like a nice face-to-face interaction. There's a trust that goes with that. It's an art to it, and that's not going away. That's not that's not going away, but there will be a different approach to expanding our patient clientele, expanding access, and consumerism. I am looking for basic information with the expectation of that telemedicine will be expanding, and if not, just for the last question. And the last one is, what type of patient visits are best for telemedicine and what are useless? Okay, doing a prostatectomy would probably be useless unless the Da Vinci robot got very good, We're family physicians, so, that doesn't directly affect us. So as far as useless, every physician is different. It goes according to your comfort level. I am comfortable doing virtual visits on most type of exam for my initial visit. And if my level of concern for higher acuity or more of a workup as far as diagnostic and physicals, then I would move that to the next appointment. So there's very few exams that I do not feel comfortable doing. Procedures, as far as, having them, doing an evaluation where then they would then need joint injections, immunizations. I think we're going to move more towards, and, this is just my opinion, full scope is good because you still would be doing those procedures when they come into your office. But I think the way that we would handle things, and I think the way that patients are going to be comfortable exposing themselves in sick situations is going to be different from here on out, as far as we know it. What is the usual copay to charge patients? If you could unmute, Lisa, if you could get on. Can you explain a little bit about the copays right now with insurance?
Can you hear me, Dr. Reddy?
Yes.
Hello? Can you hear me, Dr. Reddy?
Yes.
Okay. Fine. All payers really are different. Some, when I was billing, some did have a copay that they were responsible for. Some of the billings, they put it towards the deductible. However, every day it's changing. The codes are changing, the modifiers are changing. And now with the COVID, a lot of insurance companies are waiving those costs. So that's just to be determined as time passes. of how much the patient would be responsible for.
And if you could tell everyone about like how would the front desk check on a patient's eligibility?
Well, for us, we're affiliated with the hospital system, so we have a real-time eligibility that tells us if they have coverage for virtual medicine. Not all payers will show up on that real-time eligibility. So if we have the time, we can call the insurance to verify, or we just advise the patient to call their insurance to see, just so they're not surprised with a bill.
So Lisa and I have been pleasantly surprised because we initially started this.
Are paying.
Yeah, so when we initially started this, it was we were worried about, you know, when we're seeing patients at the office and then having to pay this direct to consumer platform, similar like they do it in urgent care or a consumer-based platform where they're paying $49 or $59. But we've been pleasantly surprised is that we are doing them a service because now it's covered by most insurances. And now during this pandemic, it's covered extremely well. And even after that, oftentimes they'll simply have a copay. And that way they're not having the burden of an increased cost by using technology. Thanks, Lisa. And Dana, if you or Carlene has been monitoring those questions, we can open things up right now. We have about 15 minutes to answer some other questions.
Okay, I will just start from the top. Can you comment on the telemedicine platforms such as Doxy.me? I'm not sure if that was fully answered prior.
Yeah, Doxy.me is an excellent platform. So what that would be is it's a free platform, and you simply as a physician, it's as simple as you log in, and you make yourself you pick an ID that's not been used. You would then the patient would also have to form their own make their own account, so to speak. And then once you are in and you are logged in, and the nice thing about the Doxy.me, you can do it through a smartphone or your computer. Same with the patient, as long as the patient has a camera on their computer. And then what you would do then is you would invite that patient via their email, or you could text them. But I think there's a little payment. That's where they get you on the payments. If you want to text it, there's a fee, but it's free if you email the patient the link. And then when they click on that link, they will be able to see you, and then you can start the visit. And you just use the Doxy.me as your document, as your face-to-face interaction, and then you would go to your native EMR that you would use in your office for your documentation. It's used as a HIPAA-compliant virtual visit. I hope that answers your question.
I'm going to wrap 2 questions into the next question. Do you have any specific advice for free clinics, given especially that many of them see lower income patients who may face barriers to care already? And then another question is, how can we promote virtual medicine to the community?
Yeah, so as far as the virtual medicine in the community, you need to, that's something you need to have nice conversations with your staff. As far as if you want to save costs, as far as going out there and marketing, those are simple conversations that you have to have with your front desk staff as far as education tidbits. When the patients are leaving the office, they say, hey, for your medication follow-up, we do have the option of virtual visit. And if you're not comfortable, we can walk you through the steps. And so that would be the best way is it comes first within your offices, making your front desk staff comfortable with the notion of this new technology, and then transferring that over to the patients. And that would be a good way. That's worked well for us. And with the socioeconomic status barriers and free, everybody's got a telephone, right? So as far as that in remote patient monitoring now, which is what we're implementing these larger health systems with COVID patients, it's just the patient on a telephone call. And then if you feel like that acuity escalates, then you move them and then you have them come into your office, right? or then you have them, but it's still billable or not billable. It's still, as long as you're documenting that conversation, it's a visit. This is like a dream come true for all the, the traditional family medicine docs that we all know that have been taking call for so many years and not being reimbursed. Now, as long as they're documenting that conversation, as opposed to just putting the phone down, and they can somehow quickly schedule that on their office schedule somehow, those conversations, then you are reimbursed for it. And you would be surprised how many, regardless of the cost of or the barriers financially, how many people have smartphones. And if they can, a simple education on how they can communicate, encourage the virtual visit, transfer it over. That's kind of my tip. Transfer it over a telephonic visit if it doesn't work. And that's the best way to market it, is try to get as many patients comfortable. Then they themselves will start relaying to their friends and family how easy, or not necessarily how easy, but how comfortable they are with the process.
The next question is, if the patient is a Michigan resident but is currently in another state, like on vacation, can you do a telemedicine visit?
If you're not licensed in that state, do not do that visit. You can do it if you're in another state as a physician, but in order to be prescribing medication or seeing the patient, that state needs to verify that you are a physician in good standing. Again, federal guidelines do not necessarily say that right now during the coronavirus, according to SEMA Burma, who released that statement and put those into effect during the corona pandemic. I wouldn't necessarily take the risk. I always check to make sure there are states that I'm licensed, because I know like Mississippi, Indiana, some others have opened up those guidelines that they agree with the federal government, and because they want to meet their demand, and so they allow other physicians to see their patients in their state. I'm not comfortable with it, to answer your question.
Can we do transition of care visits? Do you consider part of time spent during, wait, let me reread that, sorry. Can we do transition of care visits? Do you consider your documentation as part of time spent during the visit?
Lisa, can you answer that?
I have not seen anything on so far on doing transition of care visits. Not to say that that won't be in the future.
Yeah, I don't have anything to add. I have not built out a transition of care yet, and we have on our discussions, it has not come up, so it's probably trial and error right now. So we couldn't answer your question. Great question though.
There was one question asking if the slides will be available for this presentation. The slides and this webinar recording will be available on our website within the next couple of days. The last question is, do we need special informed consent statement in the note? We national legal teams I've spoken with do recommend, yes, that you add not an informed consent, just like the same way you would have your consent filled in office annually is our recommendation. Based on the platform you're using or whatnot, you should definitely get a consent from patients. I believe it's once a year, but in the note, what I have documented, and I've basically put a template in, is stating exactly that what I had initiated on that conversation is that where their location was, confirm their date of birth, confirm their medication, allergies, and that we've discussed the limits of telemedicine and virtual care, and I still have their patients obtained permission. Set that up as a template. Set that up as a template if you can, based on your EMR, is what I would recommend, because you're going to be hitting that a lot.
All right,
Bob
and
Jackson,
Dr. Reddy,
looking around, is Medicaid allowing the 99212 to 215 by phone? Lisa, do you have an answer to that?
Yeah, Dr. Reddy, if you're just doing a virtual visit, you can bill the 99212, 3, and 4, and 5. But if you're just doing a telephone call, it's a different code, and Medicaid, Medicare are paying for those. Those telephone call codes are 99441 through 9943.
Right, those are time-based, those telephone. And that Medicaid is reimbursing for those too, Lisa?
Yes, they're supposed to be. Medicare and Medicaid, yes, both of those. They're supposed to be.
Dr. Hamed, are patient satisfaction scores weighted as heavily as they are now? Patient satisfaction scores are all, from direct to consumer, they're heavily weighted. However, with everything, supply and demand, they're not as important now because of the sheer volume. Now, sometimes you are going to get a 1 out of 5 star for technical issues. So that'll happen. You take those into consideration. But, what we have seen, as I told you, the trend is patient satisfaction scores are higher with virtual visits than they are with in-person visits. They also are inversely proportional, which is very interesting to the time spent. So the longer you spend with the patient in your office, the more they appreciate you. The less time you spend with the patient on a virtual visit, the more they appreciate you. That being said, we practice good medicine. We have virtual care guidelines. Antibiotic stewardship is something we teach as far as going through those conversations, especially with patients who aren't established with you, who are newer patients, as far as relaying to them that, antibiotics are not indicated. And of course, those are always tough conversations, but we want to make sure that the guidelines we set are equal and oftentimes better than we typically would inside of an office, so that we know that we are not that we are not, by using this modality, not practicing good evidence-based medicine.
One last question, Dr. Reddy. Are modifiers different depending on health plans?
Lisa?
Yes, they are. For the 99212 through 99215, for commercial payers, you use the GT modifier. And for Medicare and Medicaid, you use modifier 95. All payers really are different. Most payers on those codes also want a place of service code of 02.
Just to be sure that this was clarified, and this is our final question, it says, can you clarify modifier GT versus 95? Who needs what?
Yeah, did you guys hear me? That's what I just went over. The GT modifier is for commercial payers and 95 is for Medicare and Medicaid.
So, before we end, thanks, Doctor, I'm on the practice management committee with Dr. Dvorak, Dr. Jackson, and they had kind of encouraged me to do this talk. And Dr. Jackson, who is quickly becoming an expert himself in telemedicine in his practice too. So I'm really happy to see that. And, we work, even though I work for a large health system, went from a small group practice to solo practice, and I'm extremely passionate about about virtual care and telemedicine. And our goal through the Michigan Academy of Family Physicians is that we're all one. We are not, whether we're employed or in academics, no matter which way we serve. My goal of this was simple in this hour is to, things are going to be trial and error. Get your feet wet, get comfortable. This isn't going anywhere. And the beauty of this is that we family physicians finally are the physicians who will be in the front lines of this platform and of digital health, because we are serving everybody, and whether it be rural, urban, all socioeconomic status. And so I'm glad we can use the Academy here to continue to share that information and collaborate in any which way possible. So thank you very much for giving us your time.
All right. And on behalf of the Michigan Academy of Family Physicians, thank you so much, Dr. Reddy. We really appreciate your time and just sharing your perspective on telemedicine. This concludes this evening's webinar, and please visit the MAFP website at mafp.com for resources as well as future webinar topics. And also, if you do have a topic that you're interested in having us explore as another webinar opportunity, please don't hesitate to contact us here at the MAFP office. Have a great night and be well. Bye-bye.